get this to go there. So I really got to thank Francesco Franceschi. He's already left today, but he was really the pioneer behind this book here, Revision Shoulder Arthroplasty. So there's some really good tidbits, tips, and tricks in this book. So what I was going to talk about over the next 45 minutes, no, I'm just joking, over the next 15 minutes is just some of the general considerations when talking about revision, my workup, and then I thought I'd take a deeper dive into the humerus because I think we've learned a lot about the glenoid. So from a high-level view, this is me flying into Athens, looking out the window. When we think about revision, we have to rule out infection. We have to think about the implants that we have in. Are they easily revisable or are they convertible? How easy is it going to be to remove? How much bone loss that we're going to obtain or have when we have to remove them? Do we have revision implants available? And what about the soft tissues? So the other important thing to think about is the patient that we're operating on. Are they an acceptable host? Do they have cardiac disease? Are they going to last through a 3-hour operation? So you want to make sure that they're an acceptable host. The other thing that's really important, and we talked about this earlier on, is are we able to get them a predictable improvement? Meaning many times they may have radiographic failure and they may not be having a lot of symptoms. So you have to decide, if I'm going to do a big revision, am I going to make them symptomatically better after they've rehabbed, after their complex revisions? So those are things that I try to consider, and that many times patients may have a radiographic failure, but it's not worth revising them because they're symptomatically doing well. And if they can get to 80 degrees and then I do a complex revision and get them to 100 degrees, is that a huge perceptible improvement for them? And it may not be, and that's something you have to consider. Where's their prior incision? Obviously assess the axillary nerve, and not only the axillary nerve, we got to assess the deltoid, because many times what we'll find in people that have had multiply operated on shoulders, they may have absence of their anterior deltoid, or they may have deltoid dehiscence. So the nerve may work, but the muscle may not work, and it can be the other way around also. You may have a nerve injury, but the muscle's also affected. So what about the workup of a person for a revision? I try to get the operative reports, the previous stickers, so I know the implant that was put in. As Ofer mentioned, some implants have moved and have migrated over time. And so a screwdriver that may have worked for generation 1 of an implant to convert it may not work for generation 2. So you want to know exactly what implant's in there. Historical radiographs, you can get an idea of how things have failed over time. Scaled bilateral x-rays. I'm going to pause there for a moment, because this is something that was very important to me, and it was a game changer in my ability to manage revisions. So in any patient that has absence of the greater tuberosity, I would strongly recommend getting full-length AP humerus x-rays with a radiographic marker. And the reason is, if you look at these two x-rays here on the right, that's patient number 1 and patient number 2, they're both dislocated reverses. They have absence of the greater tuberosity, but they're very different. So I obtained bilateral scaled x-rays, so I looked at their contralateral normal side and I measured the amount of bone loss. So patient 1 has 7 centimeters of bone loss and patient 2 has 1 centimeter bone loss. And the reason that's important, with 1 centimeter bone loss, we can do what I call a revision light. We can upsize the poly, we can increase the lateralization, we can make up that 1 centimeter of bone loss. But with 7 centimeters of bone loss, that's very challenging to make up. Essentially, the only way to make up 7 centimeters of bone loss is to revise to an allograft prosthetic composite. So that's been a game changer. If you ever have absence of the proximal aspect of the humerus, get full-length scaled x-rays to measure the full length of the humerus and compare it to the contralateral side. Rule out infections, obviously important, and getting a CT scan. A CT scan on a painful anatomic helps me look at the rotator cuff to see if it's intact. It also lets me get an idea if dye is tracking behind the implant. Revision software planning, we talked about this earlier on today, that it's very important. It's now become a routine part of my practice is to plan every revision operation. So ruling out infection, I'm not going to talk a lot about that because that's kind of out of scope, but certainly in patients that have a painful arthroplasty, that I've gotten blood work and it's normal, or an aspiration that's normal, but I'm concerned, I don't hesitate to do an arthroscopy. And I know that's very controversial, but the reason an arthroscopy helps me rule out definitively whether or not they have infection, so then I can retain implants. It also maybe give me a reason for failure. So if I'm scoping a shoulder and I see metallosis, then I know that maybe they have a loose component. I take 5 cultures, and especially if I'm considering keeping the implants, it's a very important thing for me. So here's what I do at the arthroscopy. I try to go in there dry. I try to take 5 synovial samples. I look for metallosis. I try to assess the rotator cuff, and I assess the implants. If you look at this x-ray here on the bottom left, this is a patient that was referred with a painful total shoulder arthroplasty. I couldn't figure out why they're having pain. Their blood work was normal. So I thought, this implant does have some history with some polyethylene problems, so maybe the polyethylene was loose. So I decided, why didn't I scope them just to make sure they don't have an infection? We'll take 5 samples. So I thought the poly would be loose on the tray, but if you look here, the tray was loose on the bone. So it's an uncommon complication. So I've never been disappointed in scoping someone to get an idea of why they may be having pain. So this is a very different revision that I have to be prepared for rather than a revision of a poly disarticulation. So I want to have bone graft available and a longer stem glenoid implant. So revision software, as I mentioned, I plan every one of my cases. So this is a relatively straightforward revision. We have a stemless anatomic. We can go ahead and remove the previous implant. We can segment it out. We can size the humeral component length, whether you want to revise this to a short stem, to a standard length stem, or to a long stem. We can also look at the glenoid. So in this case, I'm going to use an augmented base plate. I can measure the bone loss in the central peg to determine whether the peg that I have in my revision base plate is going to be able to fix in there. So you can see there. But because with an anatomic polyethylene, typically the central post is a little bit higher, I'm going to put my base plate a little bit higher, but then to get the correct amount of overhang, I'm going to go ahead and use an eccentric sphere. So revision planning software has certainly been very helpful for me. So now let's take a little bit of a deeper dive within the humerus here. Oh, sorry, let's go back. The humerus. Okay, so let's talk a little bit about stem removal, which is kind of a fun topic. I think one of the most important things when you're removing a stem is to know the stem that you're going to remove. So there's many different stems out there. They all have variable lengths of bone on growth or a variable different surface. And you want to know how long that surface is because that's how far you're going to have to go down to remove that. What I also have is I have a retrieval lab. So if I'm taking out an implant that I've taken out before, I'll actually go look at it again because you'll never get an idea. Sometimes there's fins in one location that you didn't recognize or you're going to forget. So you have to remember, you have to really get in there and clean that cement out or that bone on-growth surface out to get the implant out. Now, another instrument that's one of my favorite instruments is a microsagittal saw to actually remove an implant. So many people like to use osteotomes and burrs. I will use those, but this is my favorite instrument, and I'll tell you why, because it removes bone. When I use an osteotome, it actually occupies space within the implant to bone interface, and so has a higher risk of fracture. So with this, it actually goes ahead and removes bone. So we're gonna go through what I do. So with a stemless implant, I think they're very easy, relatively easy to remove. They have all these little holes in there, allows you to get in there. Now with a stemmed implant, I have a very systematic approach to remove. I take the head off first, and then I refresh the cut. So I take off anywhere from 2 to 5 millimeters of bone at the junction there, and I keep that bone because you never know, you might need that for bone grafting the glenoid. So once I've removed that, then I can really take a close look at the implant to bone interface. And then what I want to do is I want to get an idea of how long that bone on-growth surface is, and I measure it on the saw, and so that I know when I'm going to remove this, I'm going to go into that depth, and this saw is a hand saw, so it's flexible. So as I push into the medial calcar, it flexes, so that allows me to remove that bone that's contacting the implant. The other key thing is whenever you take an implant out, my advice is to hit it in first. I put the inserter on, I give it a good hit in that breaks up that bone on-growth surface, and then I hit it out, like so. So this is a patient here, this is short stem implant, so this is a relatively quick and easy revision. So I'm just going to play this video live right here. So to give you an idea how this can be effective at removing implants. So I know the bone on-growth surface is about 2.5, 3 centimeters down. So then I'm just going to start working around this implant. I think this video takes about 1.5 minutes. And it doesn't work for every stem, but it works for a large majority of stems. And you can get shorter and longer saws to get down in there. So I'm just going to start working my way around. I'll work the back. You always want to remember the back too, because that's an area we commonly forget. And then I'm going to work on the greater tuberosity. The two things that have decreased my complications during a revision, the first thing is getting the bilateral scaled x-rays. I think those have been a game changer for me. The second thing is that when I'm doing a revision, I usually try to keep the humeral stem, revise the glenoid first, put the glenosphere on, and then go back and take off the humerus stem if at all possible. The reason is I found before, when I was taking the humeral stem out first, I'd have a thin shell of bone, and I have a higher rate of greater tuberosity fractures. Even if I put a trial implant in, it's not as good as keeping the native stem. So I'm going to hit it in first to break up that surface. Bang, bang, come on, hit it in. There we go. Hit it. Hit it, there we go. So hit it in, and then it comes out. So you can see the saw has been very helpful, very efficient versus then using any sort of router trip burr. So what about a more complicated stem? So this is a press-fit long stem implant that was cemented in. So for this one, we're going to try to get it out, but you can imagine it's not going to come out. We're going to make it a little more fun and a little more challenging. So what I try to do, I try to make a short episiotomy first. If that doesn't work, then I'll do a full length. And if that doesn't work, I'll use a full length window. And I think the key is the full length window. We're going to go all the way here, all the way around. And what I try to do is I try to actually preserve the pec attachment onto that window. But how can I ensure that I'm not going to propagate the fracture? I usually get a drill, and I drill little holes right through the pec tendon so that the fracture osteotomy goes through that, so I can kind of control that like a postage stamp. So let's start the operations. This is the previous incision. It was an axillary incision. There's the coracoid. So I'm just going to make a delta pectoral incision. But I know this is going to be a challenging case, so I'm actually going to mark out my entire incision, because if I need to do a 15 centimeter window, I'm going to have to identify the radial nerve. And so if I think about that ahead of time, the jump from going to the delta pectoral to the full-length Henry approach is not that far, because I've already thought about it. If I need to do it, I'm going to prepare for it and go ahead and search for the radial nerve. So let's just fast forward. Okay, so here we are. So we're going to remove the head. This is what we call the head popper offer. That's my fellow there. He's hitting. Come on, harder. Yeah, another hit. Come on. And there it comes off. So what I'm going to try to do is I'm going to try to use a saw, but this is a cemented long stem implant. I don't think this is going to work, but it's always better to try not to do an osteotomy. So I'm going to try to work all the way around, and eventually I get frustrated and it's not going to come out. So now I've put on the inserter. So there's a little device that I've put onto the stem, and now I'm going to try to get the stem out. And it looks like it's stuck. So that's the extractor that's now stuck on the stem. And now I'm trying to get the extractor off. So I'm going to hit the extractor to try to get the extractor off. I'll put some vice grips on the extractor to try to get the extractor off. Come on. You can't make this up. So now I'm trying to hit the vice grip to try to get the extractor off. My fellow's getting there. So this is just us trying to get a stem out. You can see it's always these unanticipated challenges. Eventually I get frustrated. I leave the extractor on, and now we're going to go ahead and do our window. So I'm going to fast forward here, and we're going to go ahead and identify the radial nerve. And once we identify the radial nerve, my advice is if you're going to do a cortical window, do the full length of the implant. Don't go short. If you go short and just want to keep 1 or 2 centimeters at the bottom, you're going to regret it. There's a higher rate of fracture, and it's still hard to get down there to get the stem out. So there I went. There's the radial nerve. And this is a long stem, 150 millimeter stem. I'm going to go make my window medial to the deltoid insertion and medial to the pec major insertion. So medial to the deltoid. So there you can see I'm going to start at the biceps groove, go down, go medial to the deltoid insertion, right down to 15 centimeters. And then as I work my way up, I'm going to go ahead and drill those holes through the pec tendon so I can propagate the osteotomy in a predictable manner. And then we're going to go ahead and open it up. I'll fast forward here. There we go. We're going to keep on working, and eventually we open it up. And then once you open it up, we can go ahead and now start removing the cement. So this is a long stem cemented implant, so this is not a quick operation. So you really want to be sure that you're going to make these patients predictably better after you choose to do an operation like this. So eventually we'll keep on working, we'll work, and we can get the implant out. There we go. So we revised a short stem implant. Now we revised a long stem implant. But now we have to talk about what are we going to do to manage these bone loss. So this patient got an allograft prosthetic composite. So let's talk about the classification. So we talked about taking the stems out. Let's talk about putting stems and bones back in. So this is a good classification called the Farrow's classification. Essentially, it divides it up into epiphyseal bone loss, metadiaphyseal bone loss, and then diaphyseal bone loss. So let's go through each one of these very quickly. 1C is bone loss in the calcar. The options are you can ignore the bone loss in the calcar, you can put on medial strut on, or you can put a cement medial calcar. My preference is to just ignore it. So here's a patient, this is a stemless anatomic TESS implant. You can see that there's medial bone resorption. So this is a type 1C bone loss for the proximal humerus. I just put a standard length stem in, and there you go. This is at 6 years follow-up. So medial calcar bone loss I don't think is a big deal, so I just tend to ignore it. There it is right there. What about 1G bone loss? This is absence of the greater tuberosity. I think the greater tuberosity is very important, so the options are you could ignore it, you could make a cement greater tuberosity. This is an x-ray that was given to me by Pascal where he's actually made a cement greater tuberosity. You could do a mini allograft prosthetic composite, you can do a mini endoprosthetic as you can see here, or you can do a regular endoprosthetic. My preference in this case is to do a mini APC, and I'll show you. This is a patient that I had serial x-rays on, had a reverse done elsewhere. You can see there's absence of the greater tuberosity. The patient became unstable. The surgeon put on a spacer. The patient became unstable again. The surgeon put on another spacer, and then it was referred for us for management. And so there it is, dislocated with 2 spacers on. And what I did is I actually secured on a mini greater tuberosity with cerclage wires, and he's been stable for 5 years. So the greater tuberosity is a very effective volume-occupying bone reconstruction of the proximal humerus that will enhance stability. So mini APC. Now, what about the 2B and the 3B? This is bone loss in the diaphysis and metadiaphysis. In general, we have 2 options. We have allograft prosthetic composite, or we have an endoprosthetic tumor prosthesis. These are the advantages and disadvantages. There's an excellent article out there. My preference is to do an allograft prosthetic composite. So how do I do an allograft prosthetic composite? I tend to use what's called an overlapping flange technique. So if you look here, I put a large overlapping flange. So I don't do a step cut. I like to use a large overlapping flange because it creates a large surface area for bone healing rather than a small step cut. So I get a larger surface area for bone healing, and I enhance the rotational stability with the plate. So how do we do that? Well, just like I said, bilateral scaled x-rays, we measure the bone loss. In this case, is 8 centimeters. So I'm going to do the exact same with my allograft prosthetic composite, measure the same, maybe go a little bit more, create a large flange, and this flange can be lateral, it could be medial, or it can be anterior or posterior. So you can put that length of that stem or that flange anywhere you'd like. And then we're going to go ahead and prepare our allograft just like you would prepare a normal reverse. And then once you've done that, you have 2 options. You can cement in 2 stages or cement in 1 stage. My preference is always to cement in 1 stage, but if I can't do it, I will do 2 stage. So there we've cemented and made our allograft prosthetic composite, like so. And then we're going to go ahead and cement that into the native bone. And then at the area of the overlap, you're either going to cerclage it or put a plate on. In general, now my preference is to do both because I find the plate gives me better rotational stability. So in summary, this is an excellent book authored by Francesco Franceschi. It goes through all the steps of revision arthroplasty, rule out infection, know what the implant is that is in there, how hard it is to take out. One thing that's also been helpful for me, if I was revising an implant that I've never revised, so if I was revising a verso, I'd probably email Ofer and ask you, what's the easiest way to take this out? So don't be afraid to email your friends that have experience with different implants because it's going to make it much easier when you do that operation. You have anticipated bone loss, and you'll also have unanticipated bone loss, such as fractures. Have good revision implants and practice good technique. Thank you.